Hello, I'm Lauren Floyd. In this poster, I'm going to explain to you the work I've done under the supervision of Dr. Brooks on risk factors and risk predictions in anti-glomerular basement membrane disease, also known as anti-GBM disease. This is a rare aggressive vasculitis that typically presents with severe kidney dysfunction and pulmonary hemorrhage. The need for renal replacement therapy at presentation is not uncommon, and many patients go on to develop end-stage kidney disease. Currently, no validated risk prediction tools are available in this disease group to identify those that might benefit from immunosuppressive treatments. We undertook a retrospective and multi-centre cohort study and collected data from 2005 to 2021. This included data from 6 international renal centres. We looked at risk factors for end-stage kidney disease and applied the validated Anchor renal risk score for its prognostic value in anti-GBM disease. In total, 135 patients were included in the study, and there was a slight female predominance with a mean age of 56 years. The renal risk score applied included parameters including renal function, percentage of normal glomeruli, and degree of tubular atrophy and interstitial fibrosis. On the left, table 1 shows clinical outcomes according to the renal risk score. To the right of that shows figure 1, and this shows kidney survival based on the risk score. And as you can see, the higher the renal risk score, the worse outcomes and reduced chance of kidney survival. Overall, the renal risk score showed good prediction of kidney survival in those with anti-GBM disease. We looked at risk factors for predicting end-stage kidney disease in these patients and showed the percentage of normal glomeruli and initial need for renal replacement therapy were both independent risk factors. In those that needed dialysis at presentation, the percentage of normal glomeruli predicted renal survival, and this is shown in figure 2 and figure 3 below it. On multivariable modelling with further categorisation of patients into the need for renal replacement therapy at presentation and the percentage of normal glomeruli, and we showed there was a significant difference in renal survival. Figure 4 shows kidney survival according to the 4 defined groups, and these are explained in the figure legend. Renal survival was highest in the patients that did not require renal replacement therapy at presentation and had a high percentage number of normal glomeruli. Grouping patients in this way increased outcome prediction with a superior concordance to the renal risk score. In conclusion, we've shown that the renal risk score is transferable to anti-GBM disease, and using risk prediction tools based on the need for renal replacement therapy at diagnosis and the renal histology improves prognostication and can assist in the management of patients with anti-GBM disease. Many thanks for your time and for listening to this talk.